Good afternoon, everyone, and welcome to the IAFC webinar, Sizing Up That Vaccine for Firefighters. I'm Deputy Chief Billy Goldfeder. I sit on the IAFC Board of Directors, and I represent the Safety, Health, and Survival section. Today's a grim day as we have 400,000 Americans that have died from COVID-19. And as of today, 150 fire and or EMS personnel in the United States have also lost their lives due to the complications of COVID-19. The goal today is to address the questions that so many of us have. Half the firefighters in the nation have concerns about taking vaccine, and I understand that. I know I certainly gave it some thought, and many others, and there's a variety of reasons. We've seen everyone from genuine medical concerns to political concerns and everything else. But we're going to try and sort of push that stuff away today and just focus on what we know is to be the facts. And what we've assembled is a number of folks who are all fire service related, and we'll get to that in just a minute. A lot of work obviously went into getting firefighters priority, so many people were surprised when many firefighters said no thanks. And again, we're going to try and help those who said no thanks maybe gain a little bit more understanding of what the facts are versus any BS or any silliness that may be out there. And then after we're done today, you make your own decision. We also need to see and talk about implications for future pandemics and vaccines if firefighters refuse to take the vaccine. I know I received an email from a department in Florida, a rather large department in Florida, where their chief said that their workers' comp people are looking at a policy change that if someone does not take the vaccine, they will not get medical benefits or coverage. So that's one of the many things and stories we're hearing, and that is a fact. I had it verified. A relatively large department with several hundred members. Because again, in the end, the insurance folks and the workers' comp folks have to protect us. But just like going to a fire, we got to wear gear if we expect to get some level of protection. And again, we're not here to tell you what to do. We're going to give you the facts today. And joining me in providing you with those facts are Dr. Sara Jahnke. Sara is very involved in the fire service, has been for, I'm going to guess, over 20 years now. And she's a dear friend, and she also is very involved with the International Association of Fire Chiefs, Safety, Health, and Survival. So it's a pleasure to have Sara join us today. And she really was the impetus to push this toward us and say, hey, we really need to help these firefighters who are not getting the facts and those firefighters who are just relying on media information. We're going to try and provide sort of cut through that with you today. Dr. Jim Augustine, a neighbor of mine just north of us here in Ohio. Jim is a fire department medical director, obviously a physician, and served previously as the chief medical officer for the Atlanta, Georgia Fire Department, as well as the Washington, D.C. Fire and EMS Department. Very close to us is Dr. Mike Policastro. And again, their bios are on the website. You'll be able to see that. But Mike has a very strong military background. He's an emergency surgeon or an emergency physician in the greater Cincinnati area. He happens to be our department's medical director. And I asked Mike to join us because Mike is a survivor of COVID-19. And I don't mean with minor symptoms. Mike was on the brink, and he'll share that story with you as we go on. Captain Frank Lito of the FDNY, a good friend of the IFC and the IFF and many other fire service organizations. Frank Lito is with the FDNY Counseling Unit, Deputy Director, and Mike will be able to provide us some perspective from a metro standpoint, from a large area department. And they also, of course, provide EMS and fire with the FDNY. And no one took the hit of COVID-19 harder and initially than the FDNY. Lots to learn from them. And lastly is Zach Green. Zach is a former firefighter for the city of Wyoming, Ohio, is a member of the city council, But more importantly, Zach is also a survivor of COVID-19. He was in ICU. And again, we're not talking minor symptoms. So again, welcome to our folks. We're going to talk today with these folks, let them provide their perspective. We have a very rough draft of an outline, so that will allow for some very good casual but factual conversation. So let's talk first. We're going to lead in with Captain Lito. Frank, welcome. And what are the challenges and what are the opportunities as far as the vaccine? What is working, what's not working, et cetera, in your opinion?
You're muted, Frank.
There you go.
Oh, sorry. All right. The rollout here went seamlessly. It was run by our medical division and the IMT, and it couldn't have been more seamless. Before the vaccine was available, it was an education campaign by our medical doctors, by our chief of operations, Tommy Richardson, chief of department, John Sudnick, and the commissioner. So, that being said, they really did a great job of educating the membership. On the negative side, about 50% of the firefighters are accepting the vaccine, and about 68% of the officers are accepting the vaccine. So even with the education, we're about half of the members are not taking the vaccine. And, there's a varied number of reasons for that. One of the reasons is 5,000 of our members has already had the virus. So we had the actual number is 5,978 between fire and EMS have had positive tests. So about a half of the department, a little less than half of the department have already had the virus. So that may be one of the reasons that they're not accepting it. But there's a number of reasons that people are not accepting it. When we looked at the flu vaccine, which is tried and tested over a generation, we're about the same percentage of our members that accepted, about 50 to 60%. So this is going along with that.
Frank, that's an interesting comparison. That's actually really good information. So this is much more beyond just the COVID-19 vaccine. This is just a general feeling toward vaccines or beliefs or what have you. How does the numbers on the fire side compare to the EMS side? I don't mean to put you on the spot. Maybe you could provide that where the EMS folks.
Yeah, I don't have that, Chief. I just have the general fire and EMTs in one, firefighters and EMT in one lump, and then fire officers and EMS officers. So typically those numbers are older. So, but I'm not sure the reason of why 18% more are taking it that are officers.
Okay, that's good though. So your numbers do represent the entire department, not just the fire operations side.
Yeah, it's both fire and EMS.
Very, very good. Okay, interesting. So Sarah, let's kind of lead to you as far as the thoughts about people feeling it was a rushed vaccine. What do people feel that the vaccine was rushed? How did it get developed so quickly? How do we know the vaccine works as opposed to it not being a best guess?
Yep. So I actually created a little bit of a slideshow. I tried to keep it short though. So if I can get Steve to hand me the access. I will answer that it was a rush vaccine compared to other vaccines that have been developed. It was very fast, but in a good way. And to be completely honest, when I first heard about this, I was all for it. When fire service started talking about getting the vaccine, I'm like, you absolutely should get vaccinated. And then someone asked me if I was going to, and I was like, oh, well, that maybe I'll think about it. So I was all for you guys, but not so sure on me until I looked into it. And honestly, I will get the vaccine as soon as I can, now that I've researched the things that I've researched and I understand where it came from. And I was scared for exactly the same reason, because I don't want something put in my body that was done at warp speed. But there is one very central reason that the COVID vaccine was fast-tracked and what made it successful, and it's just a total money issue. So $9 billion was invested in the development and rollout of this vaccine. And it really allowed for manufacturing to be, for these companies to manufacture with minimal risk, because these governments were betting on the vaccine was going to work. And so I'll show you a slide here in a second where it shows you kind of the process of what clinical trial is, and where they typically start manufacturing isn't until they get to the point where they're past phase 3 clinical trials. So this is from the CDC, and it kind of walks you through the research that it takes to get up to the development of the vaccine is years. And typically it's a lot of, going for government funding, putting in grants to do vaccine development, and it's, a years-long process to get one study funded. And so all that work actually didn't need to happen, and they dumped the money that needed to be dumped in immediately. So then it goes to the phase 1 trials. So those are only about 20 to 100 people that they look at, and they're just looking at safety. So if they have these folks that are seeing anything that's really not working in that initial phase. Phase 2 is several hundred people, and this is really more looking for effectiveness. So what dose do they need? How should they be, titrated, those types of things. And in phase 3 is really the hundreds or thousands of people who are in a trial where they look and they compare people who get the actual vaccine against the placebo, and they do comparisons. Then it goes to FDA review, which in this instance was an emergency use. But there is, the other thing I want to be clear on is there is ongoing monitoring of adverse events for the vaccine. And so it's not like they stopped at the clinical trial and it's over. But when we talk about the concerns about long-term consequences and long-term adverse events, it's important to know that there's data still being collected every single day. So I mentioned that there was some overlap of trials, and this is from, if you want to follow the fantastic website, she's on Facebook, and she also has a website, yourlocalepidemiologist.com. She is fantastic. She's an epi person out of Texas, and she does a great job of interpreting and walking through she does almost daily updates of what's coming out in the news. But so that academic research that needed to happen had already happened when this had started. Really about 80% of the COVID-19 is similar to other viruses that they'd already started developing vaccines for. And they started the clinical trials, but you'll see that they kind of overlapped the phases. And so as soon as they started feeling like this was safe, and as soon as they started feeling like this was effective, they went to a large-scale clinical trial. The other thing that they did that you wouldn't see in typical vaccines is they started manufacturing and ramping up for that immediately. There was money for that because there was such a need that it wasn't, typically companies will wait, they'll get to the end of the clinical trial, they don't want to be starting to manufacture these things until they know that it's the appropriate investment of their time and money. That was not the case with this vaccine. Obviously governments were contracting for the vaccine long before the clinical trials ever ended. So the other ways that it was fast-tracked, there was a ton of collaboration among scientists and teams. I would say in terms of the science of COVID-19 and how it's been responded to, I think this is kind of the shining example of what can be done with science and how fast science can move. So like I mentioned, it didn't get started from scratch. There was 80% similarity with previously developed vaccines that ended up not going all the way to market. And mRNA is what they used and identified, and Pfizer and Moderna in particular have been using this mRNA approach, but this is not, it's the first time it's been used in a vaccine. It's not the first time it's been tested in a vaccine, it's just the first time it's actually come to market. It's currently being tested, I think, HIV, actually a flu vaccine, one other that is escaping me. But good news about this virus is that it is slowly evolving, which there will be some, I know we have some questions later about if the new strains that we see coming into the U.S. and that are developing in the U.S., like the Columbus version, are going to be covered by the vaccine that's out there. It's a slow evolving virus, and so it's not like, with the flu vaccine, we have to kind of do our best guess each year. They go and they think they identify what they think is going to be needed in the flu vaccine. That's not how this works. It's covered, and it's a slow evolving one. The other thing is that they tested this in so many volunteers, but the volunteers were so quick to respond. And so because this was such a crisis, because we see, and the deaths are incredibly tragic. I think Billy said we hit 400,000 yesterday, which is horrible. But the other thing that's of concern about this, and I think Mike will talk about it, is that you can have you can have the virus and not have horrible symptoms even and still have long-lasting effects. So a lot of people are getting it, they're not dying, but they are struggling, even the long adverse events are lasting months after the infection. And then, so we had a lot of people volunteer right up front. It was not hard to get people enrolled in the trial, and then there were incredibly high rates of infectivity. This thing is just incredibly virulent. It wants you to be sick. And so the high rates of infectivity, really quickly, you saw the difference between the two groups. And then fast-track publications. You've never seen, typically, you write an article, but from the time you write it to the time it gets published, like 9 months. Medical journals, and that's what you need to look at if you're looking for science on this, look for peer-reviewed medical journals and peer-reviewed medical articles, because they are getting published. The delay in publication is not what it used to be. And then, finally, just how was it fast track? It was just very, very effective. I heard a statistician say the other day that the best statistics are those that you don't need statistics for. This is from the Pfizer phase 3 trial that came out of the FDA, and you don't need a statistician to tell you those lines are very different. You can tell that the blue line is people that got the real vaccine, and the red line is people that didn't. So you also this is like the best case scenario for a statistician. If you do the fancy interocular test where you just look at it and you can tell that it's different. At the end, I'm going to give you an opportunity to submit more questions. And I'll pull this back to just know that it is coming. So if you have questions that we don't get answered in this time period, at the end I'll let you enter those and share those with us, and we'll get answers to you. And I'm going to hand it back to Billy.
Thank you, Doc. We appreciate that information. So let me convert this over to firefighter talk. So if we send 12 firefighters to a single-family dwelling fire and more resources are needed, they'd have to be called and more help would be needed because more tasks have to be performed. However, if every time we had a single-family dwelling fire, we send a third alarm assignment with 60 firefighters, we would be able to accomplish every task simultaneously and get the fire put out that much more quick. So that's exactly what we're looking at here. Typically, the average vaccine is sent with that first alarm assignment, and it gets dealt with as quickly as possible. But the money, time, resources are normally not there to overwhelm that situation. Well, this vaccine or this disease or this COVID-19 impacted our country so quickly and so fast that the world of vaccine production was funded so much better than normal, more resources put to it, so therefore they were able to get that fire put out that much quicker. I mean, that's the best use. So,
all right, so better than I did without slides.
Very good, thank you. Okay, so now let's go to Dr. Mike Policastro, again, a fire department physician and an emergency department physician and a strong background in the military. We're going to have Mike chat a little bit. So how does this vaccine work? What does it mean that it's a new type vaccine? What if the virus keeps mutating? Will the vaccine remain effective? Was fetal tissue used to make the vaccine? These are some of the questions folks wrote to us. Are there reproductive health concerns from the vaccine? That's a very valid question. And why is there a concern that the vaccine may harm women's reproductive health or make them sterile? So let's turn it over to Dr. Mike.
All right. Well, thank you for allowing me to talk. So I'm also a medical toxicologist. So one of my expertise is in understanding how medications and interact with the body and what creates toxicity, and particularly in the past with other vaccines. So let's start with just what the constituents of the vaccine are. In essence, what's this vaccine is made of. So the vaccine is made of mRNA, sugar, and fat. That's it, okay? So there's no other excipients or other toxins associated with this. A lot of other vaccines in the past, which was concerning for autism, which has been unfounded based off of several other articles, had either thimerosal, propylene glycate, several different agents that were used to fuel and preserve the vaccine. That is not the case here. So in essence, what this vaccine was produced from other cancer-based vaccines and other vaccines associated with Zika virus, MERS, and SARS. So basically other forms of infectious viruses from the Middle East that are in essence COVID-like, but a little bit more virulent in the past. So what happens is mRNA does not engage with the DNA. So other viruses and other vaccines and other medications and things will call it intercalate with the DNA. In essence, it goes inside the middle of the cell, changes the components of the cell, and moves on. That is not the case here. The mRNA vaccine goes into the cytoplasm, in essence, the gooey part of the tissue, and then involves docking to produce a protein that produces the protein that looks and resembles the virus spike protein. So in essence, that does not change any components of the cell. It's basically hijacking the cell to produce a protein. So it does not involve any change into the human cells. Therefore, it does not involve any change into the ovarian tissue. There's been several rumors that were associated that the spike protein of COVID resembled ovarian tissue and or testicular tissue, but primarily ovarian tissue, that the antibody immune response would then trigger reaction to destroy ovarian tissue. And that is completely false. That has nothing to do with this. Now, with regards to some of the other components of where that came through, excuse me, fetal tissue was used to confirm the vaccine's effectiveness. It was not utilized in any form or fashion to produce the vaccine. So any injected vaccine into humans has absolutely no fetal tissue whatsoever. The confirmation tests that were performed were based off of fetal aborted tissue from 1971 in the Netherlands. So that's a confirmation test. It has nothing to do with the production of the virus vaccine or its distribution in humans. So the other thought was that as a result of this potentially having fetal tissue, that produced an immunogenic response. And again, that's false because there's no fetal tissue in the vaccine. It's sugar, fat, and mRNA. End of story. So what was you gave me like 9 questions.
Sure. Yeah, I can go through a couple of them quickly, Mike. So you covered the safe. You talked about the virus mutating, fetal tissue.
Oh, yeah. So let me get into that in a second.
Yeah. Sure.
We clearly are seeing that the virus is mutating. So the Wuhan virus that was initially present, the COVID-19, completely changed to the European variation and then the variation that's currently in the United States. There are several other variants that have evolved from South Africa into England, back to the United States, and continuing to mutate. What they found is they've checked several of these mutations, in essence, all of these mutations, and the main still constituents of the spike protein have remained the exact same. So currently, the vaccine is 95% effective in producing an antibody response to all forms and variations of the COVID-19. Now, in the future, if the spike proteins change, that doesn't appear to be the case because they have maintained several very unique areas of the proteins that are very difficult to mutate by the way that the protein's forwarded. So it's going to be a little unlikely in the contemporary phase that a mutated virus will not respond to the COVID-19 vaccine for future protection. So in essence, what this vaccine is doing is protecting the individual. It's not, so there's very little information about the transmission decline from the vaccine. And so it's protecting the person from the pathogenic effects, meaning the disease effects of COVID-19. The spread may be reduced, but that's not proven. So it's preventing harm to the individual. I can't hear you, Billy.
Sorry about that. I'm going to lead into some safety questions on that and ask you to join Dr. Jim Augustine. Let's lead off with Jim. and then the both of you being our two physicians on this call can respond. But let's talk about safety, and I'll just kind of go through a few questions first, and you guys can jump in and join in. So I've got a couple of questions from our audience. And should we be concerned the vaccine isn't safe? Can you get COVID from taking the vaccine? What are the side effects? Should we be concerned about long-term side effects we don't know about yet? That's a great question. What if I've had COVID in the last 90 days? And how many people died from the vaccine? And Sara, you can maybe join us in that question too. So just let me speak for myself before I yield to the doctor. I got the vaccine. I had no side effects whatsoever. I had the Moderna. My arm was a little sore, but nothing else. Whereas my son, who's a firefighter paramedic, he got it. And, he was a little tired, a little woozy for a couple hours the next day. So here's two people from the same genetic pool, if you will, with different reactions. So, Dr. Augustine, let's go with you, and joining with you is Dr. Policastro.
Nice to be here. Thank you. And some would say you're from the mutant genetic pool, just so we're there. So I had just as many safety concerns as everybody in this audience had when these were announced. I talked to my partners. I'm part of a group of about 3,000 emergency physicians and PAs, nurse practitioners. We collectively discussed the 20-year development of this vaccine, and we're very sure that this was going to be as safe as any vaccine that we have had. Polio is our gold standard vaccine across the globe, and this, frankly, is developed in a very similar way. The safety so far has proven to be done very, very well. The phase 3 testing of both of the existing vaccines went very well. These are, as Mike pointed out, extraordinarily safe. They are not live organisms. You cannot get the disease from the mRNA that is in the vaccine. That is absolutely 100% clear. We know that this is safe for people who are 16 to 18 and older. We are still testing all of these, and they're recruiting, for any of you who have adolescents, they're recruiting for adolescents who will be the next group tested, and then down to age 6, and then down to age 2, and then to newborns. So we don't know about children as yet. We do know that this doesn't work as effectively as a vaccine in people who've had monoclonal antibody treatments already and from being ill with the virus. We don't know if this will work as effectively for anybody sick in the last 90 days. So the recommendation is, after you've been sick, and if you've been sick and received the monoclonal antibodies, if you'll wait 90 days for your immune system to be ready to receive this vaccine, it is likely to work more effectively. We do know that people who are actively immunocompromised on some form of active treatment that suppresses their immune system, they will not get as good effect from the vaccine. And we believe that people who are pregnant and breastfeeding, so those women, they believe that this vaccine is safe, but they do not have large-scale testing done on either group as of yet. They have not required in the vaccine line you to have a negative pregnancy test or to tell anybody that you're not breastfeeding. So those are some personal issues around the vaccine. Mike, what did I miss?
So when you talked about, the individuals that had COVID, so, I had a very severe case of COVID, and I got the vaccine as well. It's been my analysis of, a small select group, that those people who have had moderate to severe COVID, who have had the vaccination, tend to have had more severe side effects from the vaccine, including myself, which in essence manifest by severe elevated temperature, so temperatures of 102, 103, severe body aches. So pretty much most of the individuals that I've seen within the hospital system and initial reports have been that there's a little bit more severe side effects from the immune response, because in essence, your immune system has already seen this. So there's an enhanced inflammatory response from your T cells, which are creating this febrile response. As far as other long-term side effects, a lot of people were concerned about shingles and anaphylaxis. So that is not disproportionate to the number of people who would have this spontaneously. I don't believe there's a true cause and effect with this. We have seen increased cases of people with shingles who have had COVID because of the inflammatory marker. So this individuals that were initially reported with shingles, I don't necessarily think was contemporaneously related in a cause and effect standpoint to the vaccine. And the rate of anaphylaxis, I'm puzzled by this because it doesn't make sense to me, because the antigenic response to what this is not existent. So again, I think this is probably a component of individuals that have angioedema or other autoimmune type individual reactions that are not related to the vaccine proper. I think that's the same thing that they would have received with other forms of injection.
So, Mike, in that case, then, if the person has pre-existing conditions, getting the vaccine would be based upon their own physician who's treating them for the previous conditions anyway. Does that make sense?
Correct. So the only individuals that it appears to be less effective, and I think, Jim, you can clarify this as well, is that people who are on immunosuppression for inflammatory bowel disease, cancer, or transplant. So if you are inhibiting your white blood cells from reacting to your underlying disease process, the question is that will you develop a appropriate response from the vaccine? Does it make it more toxic or caustic? Unlikely. Does it make it effective? Unknown. So that continues to be a question within the transplant community, rheumatology, and people with inflammatory bowel disease, Crohn's or colitis.
Yes, I've got a 10-year-old grandson with Crohn's. So naturally, when it comes time for the kids to be vaccinated, my daughter, his mom, would work with his physician at Children's to determine exactly what the proper precautions would be or treatment would be.
Jim, would you agree with this? And this is my perception of this. So you have to look at everything as a risk-benefit ratio. And if you look at this and saying, okay, I'm on immunosuppressant drugs for Crohn's or colitis, or I've had a transplant. Well, what's a lot worse? Having severe respiratory failure from COVID, or having COVID myocarditis, or having blood clots that you now lost your transplant, having strokes that make you completely impaired? I mean, these are not benign risks from COVID that you're seeing. You're seeing significant increase in risk of neurologic complications by about 30%, an increase in risk of strokes of 30%, and potentially, obviously, fatal respiratory failure, but persistent lung disease and persistent cardiac dysfunction.
I agree with you 100%. Those are the risks that you have of getting this disease on top of your underlying disease. The only question, and as I've heard our oncology people talk, and I unfortunately have a nephew who's in that realm right now, he says you can get the vaccine, but I can't guarantee at all the results of it. And when we get beyond your active immunosuppression treatment, I'm going to vaccinate you again. So that some people will say, I've got to be safe anyway because of my underlying disease. And why take somebody else's place in line right now who might benefit a lot more than me? And so I'm going to wait until I'm through the active phase of immunosuppression for me to get my vaccine. The same for those of you who are asking in the chat box about those immunoglobulin infusions. They kind of mess up your immune system for a while. And so they've asked those of you who've gotten BAM or Regeneron to wait for 90 days for your immune system to clear. So there's not goop in there that might interfere with the effectiveness of the vaccine. And because you've been ill within 90 days, you have very active immune system against the disease. We haven't had recurrent active infections really that we know of in 90 days. So wait until that 90-day window has passed.
Very good. Jim, what upcoming options will be available besides perhaps a needle, and also can people choose which vaccine they receive? People
will be able to choose, and what is coming next will be the AstraZeneca. and then the Johnson & Johnson. I've already heard if these are approved, so this is 2 to 4 weeks, Billy, before these will go before the FDA. Both of them have gone well. They are both related vaccines developed from the adenovirus line, so a different type of vaccine. The advantage that some see with J&J is it'll be a single injection rather than 2 injections, and we have some people that will find that to be very attractive. As Mike began to point out, when you get the vaccine, you get a new software app for your phone called VSafe. And in a way we have never had before, picking up on adverse reactions. So anybody who's gotten the vaccine and loads up the app, you get a request every week to see if you've had any adverse effects or if you've gotten sick. So we are picking up, and CDC and FDA are releasing information much quicker. By 4 weeks from now, we may know that people whose name ends in E are having more side effects from the Pfizer vaccine. And so they're going to suggest when you go and your last name ends in E that you get the Moderna or one of the others. We may find that one of these is more attractive to people who are over age 65, et cetera. So that, Billy, is going to be the upcoming issue. We have never been in a pandemic where there were multiple vaccines available. And if you look out 6 months from now, it is possible that there will be an oral or a nasal spray vaccine that is available. So as we go through time in a disease where, frankly, it looks like we have lots of vaccine candidates, about 120 across the globe, and some of them later on will be more attractive to certain people for certain reasons. And so over time, there may be those choices. And it's at that point we may talk about mandating the vaccine, because across 8 or 10 or 12 choices and across the death and disability associated with this, that fire services and other organizations may mandate vaccines for their workers, much like measles, much like tetanus, and in our industry, hepatitis B.
So, Jim, real quick. So, also, there's a question listed about the Pfizer efficacy versus the AstraZeneca versus the Pfizer and Moderna. So, the AstraZeneca is a DNA basically vaccine. And as Jim pointed out, it's an adeno-based DNA vaccine. However, the genetic engineering of this does not allow it to involve itself with the cell's DNA. Now, we had talked about that before, that DNA viruses and DNA vaccines go inside the cell and involve themselves with the human cell DNA. The way that the genetic structure of this was formed, it doesn't allow itself to bind with human cell DNA. So even though it's a DNA vaccine and goes in there to then produce mRNA to produce the protein, it's genetically altered to not allow it. Now, the efficacy of this is significantly questionable, and it's why it was delayed. There was some questions with the way that the samples were taken and the administration times of this. So I don't know if the efficacy is decline related to that, or is it the stepwise process of DNA to mRNA to the protein? We do know that the Pfizer and Moderna are not even 95% effective. We'll have to see on the post-market surveillance of the AstraZeneca about the new efficacy rates. But it is correct that the initial goal for these vaccines was to be between 55 and 75%. It was just, fortunate that Pfizer and Moderna are 90% and 95% effective.
So let me use firefighter talk for just a quick question or understanding. So, and I'm going to be as basic as I possibly can. So the way I understand it, these vaccines really can't hurt us, based upon how you described it, and for the various reasons you described. Now, these newer vaccines that are coming in can't hurt us any more than you'd have a reaction to a flu shot or anything else. Some people are going to have some kind of reaction to some extent, but the vast majority don't. Now, but you've also talked about now possibly up to 50, 60, 70 other versions of the vaccine coming out in the future, are they all still based upon that same model, theory, or whatever the words would be, that it still is not attacking the body, it's simply protecting you against the virus? Do I understand that right?
Yeah, so the bottom line is it's the same platform, the same way. It's not interacting with human cells, so it doesn't change your human cells. It's just producing the protein. It's making the donuts. That's what it is. It's making donuts without actually involving any human cells.
Beautiful. No, that's great. I tend to be a real simple person with stuff.
There's another question listed that they asked that's saying, well, if you've had COVID and you get the first shot, why do you need a second? This is a huge controversy amongst current scientists in the world. So the British, in essence, are saying they actually think that even one is potentially effective enough. That's a lot of controversy. That's not what's being reported in the literature. But in essence, theoretically, what that person's saying is if you've developed an antibody response to COVID, why would you need the second one? Because you've already had the first response to it. The question will be is on the timing of this. So initially, and Jim talked about this, the CDC was saying 30 days, then 90 days, and then they were confirming 90 days. So by that point in time, the antibody response has waned. So is there still protection beyond 90 days? Likely. Is it the same robustness after the initial vaccination? No. So as of now, the recommendation is still to enhance the robustness of your production of antibodies. And Jim, would you concur with that?
Yes.
So from a firefighting standpoint, we're going to get water on the fire. We're knocking the fire down, but we're bringing a second line in just in case.
Correct.
Okay, good. You see, I'm converting all that stuff, so
right, exactly.
Self-understand what the hell you're talking about. All right, let's just.
Billy, I want to say one thing. Like rabies or some other diseases, putting the first line on the fire is about us using Regeneron or BAM. It immediately creates a chemical in the body that attacks the organism, and then you get an immunization on top of that to protect you down the line. So we have right now those monoclonal antibody treatments that people keep asking about in the chat, and we think that they help people who have the disease. They don't protect long term. That's what you need a vaccine for. And we're talking about lots of new choices coming for the vaccines, all of which we think are safe, but all of them have to go through all that phase 3 testing and determine effectiveness and which have the highest side effect rate, et cetera. So that's where we are now in the science.
We covered a number of the questions under the administration area of our notes. I think you've covered quite a bit of that. Should you get the vaccine, even if you've had COVID, and I guess when can my family get the vaccine? You just watch the news. I think that's pretty much how that's going to work out. Unfortunately, each state's doing something a little bit differently. There's no real consistency. But I don't know, I've had the feeling it's starting to come together, and we're going to see much more over the next couple of weeks. But should you get the vaccine if you've had COVID? That's probably a really good question.
And Mike already gave you the story on that he got the vaccine after he was ill. Wait 90 days for your immune system to be more ready for it. And then the answer would be, yes, please get it.
You're muted, Billy.
Thank you for having my back. There's a number of variants being discussed. The South African variant. We're starting to see other variants in the United States. Any comments about that? I mean, I don't know what really can be said about it yet, but maybe the two physicians, or perhaps you, Sarah, have some insight.
First of all, they will be called variants, so we won't call these a different species, et cetera. So they're variants. Billy, we probably saw variants when this first came in a year ago. There was a West Coast variant that was a lot less virulent than the one that came through Italy and into New York City, which was killing a lot more people. So we probably dealt with this. The vaccines are being made to attack areas of the virus that are more stable. And we believe all of the vaccines that are in the early phase of distributions here, that they will get to those same core areas, and that the early variants that make them, at this point, the UK one, which has a name B117, and the South African one, they create a more transmissible virus, but not one that is more dangerous. We believe that all of the existing vaccines now will work against those variants and many others to come. That's the way these little viruses are. They're constantly mutating. Unfortunately, this coronavirus didn't mutate the way that SARS did 17, 18 years ago. That mutation in SARS caused the SARS virus to essentially go away. We had hoped that would happen with COVID-19. It did not, and we shouldn't expect it to at this point. But we do believe all of our current vaccines will work against variants of this one as they come out.
Mike, any other comments from you on that, or should I keep going?
No, keep going. I think that summarizes it well.
Beautiful. Sara, anything from you?
I was going to say that with the vaccine, that's already been answered, but it is looking like it is more virulent than the other strains. So they are looking at, with the early data coming out about how infectious that is. Looks like we'll likely see another uptick. So just one more reason to motivate folks to get the vaccine.
Very good. So let's talk about conspiracy just for a minute. Will you have to have a vaccine card to travel? I'm starting to hear, again, it's so hard with the news today. Who even knows what news is, unfortunately? And I'm not slamming one network or the other, but it's really hard to keep up these days with fact and fiction and what have you. But do you know anything factual as far as vaccine cards being required to travel? Any chance they're going to be microchipped? Any of that kind of stuff that we can cover? I'll start with Sara since she's feverishly.
I mean, just obviously, yes. It makes sense that all these scientists from all over the world would conspire to microchip you. So yeah, it seems logical. No, I don't. Honestly, if we could, you can't. No, we're not microchipped, I think is the short answer for that. I've talked to a lot of people who are yet to buy any electronics since getting the vaccine. So I think we're good on that. But I do think, in terms of the traveling, so the latest I was reading up on this today, there are countries that require you to have a documented vaccine when you travel to that country, especially if they're a high-risk country, you're coming from a high-risk place. So there is early discussion about having that. There are a lot of places now that require you, especially coming in from outside of the country, requires that you have a negative test or that you quarantine once you get there. So I can see a scenario. I don't think that there's anything like on an international effort at this point, but places that are high risk do have where they require you to have vaccines. And I can see a scenario, especially in countries that have really gotten COVID under control, not allowing people in without a vaccine. So I think there could be some truth to that, especially with international travel at some point in time.
So, Frank, I see you smiling a little bit when we're having this discussion. Some of the greatest places to find out fiction of any fact would be in a firehouse. So maybe you want to provide some insight to calm people down regarding conspiracy, maybe anything you've heard?
Yeah, I don't know if I can calm anyone down, Chief, but a lot of dialogue goes on in a firehouse, as we're all aware. It seems like and this has nothing to do with the vaccine, but just general information. It seems like we're really doing a very good job of protecting ourselves when we're going on calls, and we're properly masked up and keeping distances and doing a really good job. Where we're getting sick and where we're getting infected is in the fire stations and the firehouse. For some reason, we don't believe this virus exists within the walls of a fire station. The masks come off. We're sitting where at the dinner table, where running drills without our mask. I sit in my office, and a firefighter will walk in. He'll look around to see if there's any civilians, and he takes his mask off. It's really important to get the vaccine, but until everybody's got a couple of doses in them, we have to protect ourselves and protect our families, and we're really not doing a good job of that right now.
Some really sage advice, and we appreciate that, Cap. I've got a few more questions for Mike and Jim and anyone else who'd like to chime in, but I do want to save time to get to Dr. Policastro, Mike, and for him to share his personal testimonial. And if Zach Green's been able to join us. Zach, anybody know if Zach's been able to join us or not yet? Just send me an indication of that. So I'll just go through a few bullet points here. What about religious concerns? Well, that's about anything. You have to follow what you believe in. Your religion was what's important to you. And speak to the leaders of the religion of your community and see what your religious leaders are recommending be done and how those situations are dealt with, and what your community recommends. Frank, you just covered it. When can I quit wearing a mask in the firehouse? Not yet is the answer. It's not time. When can we go back to public events like teaching? Again, this is going to be all based upon how well we as the general public and we as the fire service do what we can to minimize the spread of the vaccine. So let's do any of you have anything to add as far as the questions in this last area, as far as going back to normal, the religious concerns, things like that I've just discussed, before we go to Dr. Policastro for his testimonial?
Quickly, I think what will happen within our jurisdiction, so within our fire agencies, if you're vaccinated up, you get the privilege of traveling again. If you're vaccinated up, you're not a candidate for quarantine, which at this point now is not necessarily paid. Number 3, the entire crew is vaccinated. You may get the privilege of all taking your masks off in common areas. And then number 4, there may be churches, there may be social events, there may be concerts, etc., that they'll say if you either have titers or your vaccination card will let you in. Those are potentials, Billy, that we sequentially move to as we get the vaccines rolling.
Mike, any additional on this?
I think just because a lot of the fire service are also military personnel as well. So I'm one of the commanders for the 445th ASTS. I'm a critical care air transport physician with the Air Force in the Reserve. So I think, as we are seeing people going in and out of the AOR in multiple deployments, and not even just deployments to within the continental United States. So again, that quarantine may or may not still be required. Still right now, it's still voluntary in the military. Eventually, I believe that this will be mandated, just like Jim was saying. But just from a quarantine standpoint, that I don't know if that's going to be required or not. I'm going down range again in 13 months. And so, how that's going to look in a very specific AOR, I don't know. But I can tell you that it's still rampant in these other countries. If you're going outside the wire to collect, personnel and things like that, it only behooves you. So, if you're talking about your individual safety and you're a military personnel, I cannot conceivably see how you would not take this vaccine for self-protection, if particularly you're working with, multiple joint services and indigenous personnel.
Very good. So let's go right back to you and let you continue to keep the floor, Dr. Policastro. I know that you shared with us a very, very difficult situation that you went through with this. So let's let you share your experience.
So, yeah, I can pretty much pinpoint when I got COVID. As everybody else is in this massive pandemic with just multiple patients, I had one, and I was wearing my PPE. I mean, I was in full PPE, and I intubated 8 people in a row within about an hour and a half. These are all people that had failed, non-invasive oxygen, high flow oxygen, that were, severely hypoxic and in severe distress. One ultimately died that night. So the question is that when patients have a higher viral load or a higher response, do you have a greater risk to yourself despite PPE? So within about 5 days, I didn't feel right. I just felt kind of like I had a sore throat, a little bit of a headache, and I was like, this came on very fast, and this doesn't feel like a normal virus. So I got tested when I was in the ER, and it came up positive. So I was, they're like, okay, fine, quarantine for 10 days, monitor your symptoms. So later that night, I spiked to about 103 fever. I had severe body aches, and I just got a lot more rapid. And I was like, this is disproportionate to other people's symptoms. So I was monitoring my pulse ox, like everyone should be that has COVID. And by day 3, my SAT was like 90. And I was like, okay, well, I'm okay. Let's see where it goes. And I had, some respiratory symptoms, but not terrible. By day 6, my SAT started falling to about 89. And then when I exert myself, it would start falling. And I was like, okay, well, I'm a little all right. Let's see where it goes. And by about the next 45 minutes, my SAT was 65%. I was in severe respiratory distress. I was in pulmonary edema. And I just was in extremis. And I don't know if anyone's ever had, congestive heart failure, pulmonary edema, or drowned, but I can tell you drowning in your own froth and sputum and having air hunger and cyanotic and the tachypnea and hyperpnea from that, and just the immense air hunger is horrific. So I was put on 60 liters of oxygen. I was proned immediately. And so I got antibodies and Decadron and aspirin and Lovenox and everything like that. And I was proning pretty much while I was awake. They put me on 100% non-rebreather over the top of the 60% because my SATs kept falling. And at that point in time, I was like, this is bad. Like, I'm going to move to BiPAP and intubation potentially because I'm already at, a very high flow. And that's when I got pretty, freaked out because, I was isolated, alone. Nobody can contact you. How was I going to explain to my children? And what was I going to say? So, you have that sensation of impending doom. You see all these people decline. All of us are healthcare providers and take care of people that have died or have rapidly declined. So you have that immense fear. And, in the ICU, 3 people next to me died, and I'm just watching this stuff as I'm, on massive oxygen, proning myself, and thinking, I was like, because critical care walked in, they're like, okay, so in the next 12 hours, if this declines, you're in bad shape. And I was like, well, I know that. So what else are we going to do? He's like, nothing. He's like, there's nothing else we can do. And so I'm just, sitting there telling myself, okay, I have 6 hours. Can I get through 6 hours alive? And then you're just like, okay, if I can get through 6 hours, I can maybe get through 6 hours more. And so just trying to push yourself from that standpoint. I kind of, I began to respond. But right now, I still have severe cough. I'm, more than 2 months out, I have persistent cough, and you can hear the phonation deficit. I had an echo to make sure that I didn't have myocarditis so I can begin exercising again effectively for the military. I mean, I'm still fatigued. And I have 0 health problems. I mean, my body fat was, 10 to 12%. I had no lung injuries. I'm a very healthy person. I mean, I'm 46, but I'm a very healthy person. So that was my experience.
That's quite a story. And I know we followed it through our department, and obviously our hope and prayer toward you when you were going through this, but it was a real wake-up call, and I'm hoping that you're sharing this today with our audience too. I know that, Frank, you probably, I know you lost several members of the FDNY, and I just from reading reports and seeing media reports, it's a pretty similar story. It's a hellacious experience.
And it was indiscriminate, and like Michael's story, some guys just got slammed and hospitalized, and the other guy lost his sense of taste and smell, and there didn't seem to be any rhyme or reason to why that was happening, but it seemed to be happening all around us, and the fear that went through the department in March, April, and May. I've been in New York a long time, as you know, Chief. I've never seen the fear that we experienced back then.
Yeah, I mean, we can only appreciate that remotely, but close to home here, we lost a local firefighter. I'm going to ask Dr. Augustine just to share that experience. This was a death. This was everything you described, but it kept going. And so very near and dear to us. Go ahead, Jim. Go ahead.
Yeah, a 52-year-old fire lieutenant paramedic got ill, was part of a process where another 10 members of our department got ill. He was 4 or 5 days at home, 7 days in the local hospital on the high-flow oxygen, decompensated, ended up on ECMO, and died 6 days later. That is a family member, the father-in-law of my son, who's a firefighter who was one of those very ill with it also. So a tragedy. He leaves behind 2 high school kids, a healthy, thin, 52-year-old male. And that's the kind of stories, just exactly as Frank is saying. Thank you, Chief.
Yeah, to our audience, I hope you're getting the impression there's no screaming liberals here. There's no screaming right wings here. These are just firefighters talking to firefighters, just trying to get the facts out so you can make an informed decision. And Zach, have you been able to join us?
Billy, I just keep having trouble getting in. Brittany just texted.
You say he is with us?
He's not on, he's having trouble getting into this system.
Okay.
So we can put up my screen with the email address before we finish, in case people have questions on the email. And you can send out recorded, and we'll send a link out to it once it's all uploaded, and then we'll try to get to all the questions and send answers out to that too.
Yeah, so you're a little bit muffled, but what I want to make sure you said, we will answer the questions through a document. Is that?
Yeah, we'll get answers to them and send them out.
Okay, very good. Well, listen, folks, on behalf of the International Association of Fire Chiefs, I want to thank Sara, Jim, Mike, Frank, and Zach for his attempts to get in. Our goal today was just to give you some facts, no politics, no bullshit, no silliness, just real information from good people who've been there, done that, so you can make informed decisions. Special thanks to the staff at the International Association of Fire Chiefs for their help in pulling this together, and to Sara, Dr. Jahnke, who is absolutely on the front lines for us every day. While she doesn't wear bunker gear, she represents our needs and issues and does a great job in trying to protect us. So again, keep an eye for an email or a link from the IAFC where they will answer the questions you've submitted today. Today's turnout was phenomenal, and it's my hope is that we met your goal of not hearing a bunch of hoo-ha, but just hearing facts from people who've been there so you can make an informed decision. Again, thank you to Frank, to Sara, Jim, Mike, and Zach for joining us today. Thank you, everyone.
And to Billy Goldfeder for organizing this. Thank you, Billy.
Thank you. Sure. And we're also going to, this is being recorded, and this will be made available. I just saw somebody pop up with a question in the chat. Yes, this webinar will be posted either through WebEx or YouTube or whatever, but I'll make sure you get it to the IAFC, to the secret list, Firefighter Close Calls, FDNY, and everybody else. We'll get it out to everybody so you can join in. Again, thank you, everybody, for joining. Please be safe. Take care.
Great job, Billy. Thanks again.
Thanks, everybody.
Thank you very much.
Thanks, guys.